thing. So if you see, ये एक नेगेटिव प्रेशर काइंड ऑफ थिंग था, मतलब the individual is not able to take the breath and all that in 1950, तो इसको उसको एक इस टाइप के केबिन में रखा जाता था, और यहाँ पे जो उसके चेस्ट की तरफ जो होता था वो नेगेटिव प्रेशर क्रिएट होता था, एंड उसका जो नाक है और जो फेस है वो बाहर रखा जाता था, विच इज इन द पॉजिटिव प्रेशर. तो एज यू नो द फिजिक्स, सिंपल फिजिक्स की, द एयर ट्रेवल्स फ्रॉम द हायर प्रेशर एंड टू द लोअर एंड. तो उस वजह से जो बाहर की हवा थी वो इसके नाक के थ्रू होते हुए इसके फेफड़े में पहुंचती थी. तो यू कैन इमेजिन कि such kind of crude ventilator that time it was being utilized, but it is good, and it was life saving for many patients after this polio epidemic. Lot of casualties were there. So this is the basically, you just see the development of the healthcare technology. It's a part of technology. Kaise gradually now I think if you have any time visited the hospital and all, now you see a lot of sophisticated item. उनका लेवल क्या है, एंड इफ यू कंपेयर विद दिस, बट वी हैव टू स्टार्ट समवेयर. कहने का मतलब ये है कि वी कैन नॉट से कि नहीं हमारे पास ये नहीं है तो हम ये नहीं करेंगे. But people were so much creative or so much innovative kind of thing कि they use something to utilize the things in that time also. Okay. Then we talk about this ICU के जो type हैं, तो we talk this ICU is level 1, level 2, level 3 in general consideration माना जाता है. तो what is the level 1? Basically it's in the ideal for the district headquarter hospital or the nursing home kind of things. Okay, bed strength maybe 6 to 8, and यहाँ पे you provide all sorts of care. मतलब यहाँ पे multi professional teams and everybody is available. And when we talk about this level 2 hospital, that is ideal for the larger general hospital. Bed strength maybe 6 to 12 depending upon the total number of beds. Okay. And यहाँ पे जो facilities हैं, they are more complex, or you can say various other are there. And then we come to this level 3 hospital, which is found in big medical college, big corporate hospitals. Well, all sorts of arrangements are there. Bed strength may be 10 to 16, or sometimes it may be more than that. And technically, in such kind of level 3 kind of ICU, we try to make the manpower ratio, nursing patient ratio is 1:1. If the patient is on the ventilator, and if patient is not on the ventilator, so of course we can utilize the ratio of 1:3. And second, in the various part of the day, because you can imagine in the ICU or anywhere in the world, maximum consumption of time is in the morning hours, when you have to give various kind of hygienic process to the patient, sometimes cleaning, wet cleaning, or sometimes dry cleaning, and a lot of other day-to-day activities are being performed. So during the daytime you need more staff, but if you talk about the evening or later part of the evening, there is a reduction in the uh, staff need. So during that time you can do the management with not exactly 1:1. You can do that 1:3, 1:4 kind of things, depending upon the situation, critical situation of the patient also. So there are various factors which decides how you can staff your ICU. There is a no fixed formula. There is just only a guiding principle has been given कि आईसीयू में यदि पेशेंट वेंटिलेटर पे है तो आइडियली नर्स और पेशेंट का रेशियो 1 चाहिए, और पेशेंट यदि आईसीयू में है लेकिन वो वेंटिलेटर पे नहीं है, देन इट कैन बी 1:3 एंड 1:4 ऑल्सो. ओके. Now we see various kind of ICUs. This is the level of ICU: level 1, level 2, level 3. Level 3 is the more sophisticated kind of ICU which exists in big corporate hospital, medical colleges, and all that. Okay, just you have to remember. Now you see this various kind of ICUs: medical intensive care unit, that is called MICU, SICU, medical surgical unit, coronary CICU, cardiac surgery CSICU. Then you can most common thing is that TICU is there, and NICU is there, neonatal intensive care unit is there, PICU is there, that is pediatric intensive care unit, and geriatric. And now a few hospitals they have the geriatric intensive care unit also. So depending upon the specialty is you have to create this ICU wards, and the location where your hospital is located, depending upon the type of the patient you are receiving or the getting, you have to create the number of bed. You have to plan for the number of beds in that particular area, as there is no use if you are working in some in a community where the geriatric patients are less, then there is no use of maintaining this geriatric intensive care unit, because then it is not cost effective. For maintaining any kind of ICU, it is a very cost intensive kind of thing. तो बेस्ड ऑन दैट यू हैव टू प्लान कि आपका जो हॉस्पिटल है किस एरिया में है, एंड विच काइंड ऑफ आईसीयू you need. According to that, you can plan for the bed. This is a normal, just for understanding, this is a normal layout of the ICU. Beach where this is the nursing station. These are the beds in the ICUs. And if you see the position of the nursing station, that is in the center. And what is the benefit of being in the center? By sitting in the one common location, sister they can nurses or other they can monitor the patient from this area only. Okay, they can see the patient of this area, they can see the patient of this area, they can see the patient of this area. So that is the mm, purpose of designing of the ICU. Otherwise, in various hospital, you will find out some different kind of ICU. So, abhi, when you go to some, if you have any chance to go to the ICU, just see the design, what design they have done, and whether, and considering the design, there are two things. One thing, there are two, three things which you have to keep in mind. First, visuality should be good. Okay, by sitting at a location, at least you are able to see the patient, first thing. Second, movement of your nursing staff and your service providers, means anybody, housekeeping staff, lab maybe there, wo jo distance, traveling distance, that should be less. So whenever you get the chance to visit some ICU, at least just see these two things. ओके, कि हम इसको कैसे कर सकते हैं, कि हम क्या सोच के हॉस्पिटल वालों ने उसको उस तरीके से डिजाइन किया है. Okay, now we talk about this some equipments, common equipments, or many times आपको आपने भी देखा होगा आईसीयू में, somebody has gone to see that. तो आईसीयू में आपको इस टाइप के इक्विपमेंट दिख जाएंगे. There is a computer recording system is there, defibrillator is there, dialysis machine may be there, infusion pump is a common thing, monitor, multi-para monitors are there, and various kind of respirator, means ventilators, different kind of ventilators. Pediatric में different kind of ventilator is there, adult is a different kind of ventilator, and for the neonatal there is different kind of ventilator is there. These are few equipment. There are many more equipment which are available in the ICU. Gas pipeline system is there. Okay, कि गैस जितनी भी आपकी लाइफ सेविंग गैसेस हैं, ऑक्सीजन है, वैक्यूम है, सक्शन है, they are all traveling through this gas pipeline system. Gas pipeline is also one topic that I will take later on, कि गैस पाइपलाइन सिस्टम हॉस्पिटल में किस तरीके से होता है और किस तरीके से काम करता है. तो ये कुछ इक्विपमेंट है, बाकी जो और बहुत सारे इक्विपमेंट हैं, बीपी इंस्ट्रूमेंट है, लॉट ऑफ अदर थिंग्स आर देयर, सक्शन मशीन है, देयर ऑल अवेलेबल देयर. छोटे हॉस्पिटल हैं, समटाइम्स नाउ दे आर नॉट एबल टू मेंटेन दिस पाइपलाइन सिस्टम, तो वो आइसोलेटेड काम करते हैं, मतलब पाइपलाइन नहीं है तो आईसीयू में ही वो गैस सिलेंडर्स और सम सक्शन मशीन वगैरह रखते हैं. बट नाउ गवर्नमेंट हैज, आफ्टर दिस कोविड, गवर्नमेंट हैज डायरेक्टेड कि यू हैव टू इंश्योर this pipeline system to every end of the bed. Every bed end, you are supposed to maintain this oxygen gas pipeline system. and this decision was taken during the COVID, and now most of the hospital they have implemented this, and it is a benefit also because to maintain the cylinders and all that, it's a big headache, and many times you find in the hospital कि cylinder is lying empty, जब जरूरत पड़ती है तो हमें उसमें गैस नहीं मिलता है. So this kind of problem we can minimize by using this gas pipeline. Okay. Now we talk about the team ICU में टीम में क्या क्या हो सकता है. As I told you, this is a multi professionals kind of team. So we have intensivist, okay, who deals with this ventilator. Resident doctors may be there, senior residents and junior residents who perform the 24-hour duty. Nurses are there, respiratory therapists are also there. जैसे फिजियोथेरेपी होता है वैसे respiratory therapists भी होते हैं who the respiratory exercise for normal breathing. Nutritionist may be there, will be there also because they assess the diet requirement and all कि whether liquid देंगे कैसे देंगे हम उसे राइल ट्यूब से देंगे किस तरीके से फीड करेंगे they are for the physiotherapist is also there and most of the time people who are lying in the bed in the ICU there some kind of spasm some kind of immobility develops in the limbs so the physiotherapist they just move the limbs and all that according to the advice of the doctors ultimately finally they have to follow the advice whatever the advice has been given by the doctor. Otherwise, it's not like that. Physiotherapists they can start the physiotherapy automatically. But then we have technicians, dialysis, X-ray, and the computer. Biomedical engineer is very important part who deals with all this equipment which are life-saving equipment which are in the ICU. The importance of biomedical engineer is also very high. Clinical pharmacist who provides the drugs and same time he will also make ensure कि there should not be not interaction between the two drugs kind of thing. So that is the role of this clinical pharmacist. Social worker and counselor they are actually meant for counseling the patient attendant. If you see the person who is admitted in the ICU, okay, patient condition is bad, he is in the bad shape, but same times उसके जो relatives हैं या जो उनके अपने लोग हैं, they are much more mentally apprehensive, बड़े परेशान से रहते हैं. एंड कम्युनिकेशन गैप हॉस्पिटल में कुछ सिचुएशंस में बहुत ज्यादा होता है कि पेशेंट आईसीयू में पहुंच गया तो उसके बाद लोगों को पता नहीं चलता है व्हाट इज द कंडीशन ऑफ द पेशेंट. तो इन सारी चीजों को लेके दिस दिस वाज फेल्ट कि वी नीड सम काइंड ऑफ सोशल वर्कर और द काउंसलर काइंड ऑफ पर्सन who can counsel the patient attendant as well as sometimes patient also because all the patient they are not on the very serious kind of condition. Gradually they are improving also they need also some kind of counseling to just make their mental setup positive and all so that early recovery can be done or the complication can be minimized. And then we need the support staff in any area we need support staff color cleaning staff we need attendant we need security guard that is very important security guard duty is there. And we talk about the ratio as already I told you in ICU nurse patient ratio technically it is considered 1:1 when the patient is on the ventilator, but if patient is not on the ventilator then it can be 1:2, 1:3, 1:4, and that also depends upon the illness of the patient type of illness of the patient and um, uh, time of the day. Okay, as I told ki morning may requirement may be more so that time you can increase the you can put more nurses or more staff on the duty and gradually you can by the evening or by the night you can just reduce the number of the staffs and all that kind of thing. So that is a basically planning and that is all the role of the hospital administrator, hospital manager, or something like that, based on the what trend is going on in your hospital. Okay. Now we talk about this admission and the discharge criteria. It's a very disputed kind of thing. कि हम किस पेशेंट को आईसीयू में डालेंगे किसको नहीं डालेंगे. Many times you just heard or listen or you just came across कि there is a news कि पेशेंट को unnecessarily आईसीयू में रखा एंड उसका बिल बनाया ये किया वो किया. तो ऐसे केस जब कोर्ट में जाते हैं तो दैट दैट टाइम इट these guidelines they are helpful in decide decision making कि whether the patient has which has been kept in the ICU, whether it is justified or it is just sake for the monetary benefit and all that. So that's why this admission criteria and the discharge criteria is very important. I think the government has also made some kind of issued some kind of policy regarding this admission and the discharge criteria, but still it is not related with the legal. Means if you violate, there may be some action, or it's something not like that. Okay. तो एडमिशन क्राइटेरिया में हमें देखना है जो पेशेंट हैं जो हु कैन नॉट सस्टेन बाय देमसेल्फ मींस दे नीड सम काइंड ऑफ रेस्पिरेटरी सपोर्ट ओके एंड दे नीड आल्सो इंटेंस मॉनिटरिंग एंड द थेरेपी फिर देन वो पेशेंट जिनमें वन एक से ज्यादा ऑर्गन मल्टी मल्टी ऑर्गन फेल्योर है या दो ऑर्गन फेल्योर हो रहे हैं दैट पर्सन कैन बी एडमिटेड टू द आईसीयू फिर क्रोनिक इम्पेयरमेंट हो सकता है मल्टी ऑर्गन फेल्योर हो सकता है एंड वेरियस काइंड ऑफ मल्टी ट्रॉमा काइंड ऑफ थिंग्स हो सकता है वो भी पेशेंट हमें आईसीयू में रखने पड़ते हैं फिर रेनल रिप्लेसमेंट है और जिनका जीसीएस है जो ग्लासको कॉमा कॉमा स्केल है दैट इज लेस देन 8 and patient is in the shock, then he can be admitted to the ICU. Many cardiac patients, chest patient initially, after the surgery, they can be kept into the ICU for the observation for few hours or few days. लेटर ऑन धीरे धीरे हम उनको स्टेप डाउन करते हैं सीधा हम पेशेंट को आईसीयू से कभी भी पेशेंट को हम डिस्चार्ज नहीं करते ये जो मैंने लिखा ना एडमिशन एंड डिस्चार्ज क्राइटेरिया एडमिशन इज फॉर एडमिशन एंड डिस्चार्ज मींस फ्रॉम आईसीयू टू स्टेप डाउन directly we never discharge the patient directly from the ICU. Always we do the step down. Or in any case, if in any eventuality for the God, it's very unfortunate if some patient died in the hospital. That is an entirely different kind of thing. But in the ICU, we take the patient into the some other ward. That may be the intensive ward, but that is less than the ICU. Then from that we shift the patient to the general ward, and finally, the general ward means a common ward kind of thing. It may be the private ward also. जनरल वार्ड से मेरा मतलब है ट्रीटमेंट के पॉइंट ऑफ व्यू से इट इज नॉट सो मच इंटेंसिव वहां पे हम लेके आते हैं और वहां से हम उसको डिस्चार्ज करते हैं आइडियल सिचुएशन इज समथिंग लाइक दैट you should do the step down then you have to discharge okay the patient talk about the discharge criteria as I told you कि we are doing the step down kind of treatment patient को हम नीचे लेके आएंगे नीचे वाले स्टेज में कि उसको वार्ड में शिफ्ट करेंगे then from the ward patient can be discharged no in normal situation no patient is directly discharged from the ICU okay so this word discharge criteria is actually यहाँ पे this is not correct word it is the actually discharge नहीं it is the step down criteria from the ICU. It is something like that. It should not be discharge criteria. Okay. उसके बाद criteria जो इनका continued है अच्छा in there are in certain position in certain conditions when we have to perforce discharge the patient or from the ICU directly also there are certain situations. Okay, what situations may be there? These are only after obtaining a written discharge ordered by the attending physician, discharge can be done when the patient is stabilized and no longer requires mechanical ventilation or active support for more than one organ. Okay, उस कंडीशन में भी हम पेशेंट को पहले स्टेप डाउन करके नीचे लाएंगे फिर दूसरा स्टेज ये होता है पेशेंट इज नो मोर बेनिफिटिंग फ्रॉम द ट्रीटमेंट अवेलेबल उसको हमें आईसीयू में रखने से वी डोंट हैव एनी यूज तो सम टाइम हम पेशेंट को डायरेक्ट घर के लिए भी डिस्चार्ज करते हैं वी टेल द पेशेंट अटेंडेंट कि आप इसे घर ले जाइए एंड जस्ट लुक आफ्टर एट द हाउस देयर इज नो पॉइंट टू कीप दैट पेशेंट एट द हॉस्पिटल एंड सम टाइम पेशेंट के फैमिली मेंबर्स और पेशेंट के जो रिलेटिव्स हैं दे गिवन राइटिंग टू द शिफ्ट द पेशेंट फ्रॉम इंटेंसिव केयर टू द नॉर्मल वार्ड और केबिन I told you about this stepping down. This is the stepping down only. तो कभी कभी होता है और इंडिया में ऐसा क्यों हो सकता है इंडिया में ऐसा इसलिए हो सकता है मैक्सिमम जो कॉमन रीजन है दैट इज द money constraint financial protection even this Ayushman Bharat Indian government they are able to provide good medical coverage up to the 50 crore people or something like that but still the out of pocket expenditure in India is on very higher side and many times this patient family or they give in writing to the patient that is because of the money constraint. And sometimes the patient है वो persistent vegetative state में चला जाता है, मीन्स coma kind of stage में चला जाता है, then there is no point to keep the patient into the ICU. That time also patient with the consensus of the patient attendant or the family members, patient either can be shipped to the house also, and sometimes if nobody is there to take care of that, then patient can be shifted to the some other normal accommodation of the hospital for a period. Okay, and there are special conditions for the discharge from the intensive care. But clinically, there is a minimal chance of survival. Then there is no point to occupy the bed. When death is imminent, मतलब आदमी को पता है, and in the ICU, people and the doctor they come to know this thing. Okay, there is survival chance, whatever the survival chance is there. There are a lot of scales are there which just predict what is the survival in the patient in the ICU. So in that situation also, a patient may be shifted to the other, and sometimes in our ICU और मेरे हॉस्पिटल के आईसीयू में ये उतनी फैसिलिटी नहीं है, then we also need to shift the patient to the other ICU in the other facility. That is also one thing. But maximum case में भी सही कि hospital they just keep the patient in the ward in the ICU for just monetary benefit. That is actually wrong practice, and some kind of regulation, some kind of rules are required. And as a hospital administrator, you must ensure that is where this admission and the stepping down criteria laid down SOP is very much important to just gain the just win the trust of the patient or the patient attendant. Okay, this critical care is a very big issue because it's a very cost intensive kind of stay. That is why everybody thinks कि डॉक्टर ने सही रखा है या गलत रखा है. और मेडिकल में जो सबसे बड़ा प्रॉब्लम है दैट इज द इंफॉर्मेशन एसिमेट्री. डॉक्टर जो बोलता है पेशेंट को उसका एबीसीडी नहीं पता होता है. यदि डॉक्टर बोल दिया कि पेशेंट को आईसीयू में रखना है तो वो रखेगा, बिकॉज पेशेंट या पेशेंट का अटेंडेंट या फैमिली मेंबर they are not aware. So that is the one of the big problem in the medical setup, which that particular word is known as the information asymmetry. That may be for the clinical care and that may be for the anything. Okay, so that is also a big issue. तो हमें कोशिश ये करना है लोगों को हम same time educate भी करें. As a hospital administrator, it is our responsibility also. We should educate the patient also with the consensus of the management team of our hospital, something like that. Okay, and द पर्सन जो परमानेंट वेंटिलेटर पे हो गया है, जो एंड स्टेज रेस्पिरेटरी फेल्योर में चला गया है, उस केस में भी समटाइम्स हम फैमिली मेंबर से डिस्कस करके वी कैन डिस्चार्ज द पेशेंट टू द होम एंड मेंटेन द कंडीशन. ओके, नाउ आईसीयू में दिस इज द केस एग्जांपल, केस हिस्ट्री काइंड ऑफ थिंग. नाउ द कोविड इज बिकम अ पास थिंग, तो देयर इज नो पॉइंट टू डिस्कस ऑल दैट. बट उसमें हुआ क्या था, हैंडलिंग शॉर्टेज ऑफ बेड, लॉट ऑफ बेड्स आर पीपल, लॉट ऑफ पेशेंट्स आर देयर बट वी don't have enough number of beds which is supported by the ventilator. That is the big problem during that phase. And if somebody has worked in that period, as a particular I worked in some medical college during that period. Even we have ventilators, but sometimes we don't have any intensivist. Because many intensivists they become infected, they are not ready to work in the ICU or something like that. That time we have to train our lower staff, means nursing staff and the operation technicians, to just work on the ventilator and all that. So that is a very unprecedented kind of situation in the COVID, where we have utilized all kind of ways and means to give the healthcare to the patient. Okay, by and healthcare provider, they have taken a lot of risk, they have shown a lot of courage, they have shown a lot of dedication to treat such kind of patient, even putting their life at stake. So that is the kind of thing, and that is why even the America, British, who are very very rich country, or you can say जहाँ पे हेल्थ केयर पे जीडीपी का हम 10% से लेके 15% यूज करते हैं, जबकि इंडिया में वी आर ओनली यूटिलाइजिंग 1.5% of the GDP. The huge difference is there. But even the public satisfaction during the COVID time in India, this this is a research study. It is not like that कि I am telling to आप मान लो. This research has been done, and that time public satisfaction in India is on very higher side, even compared to America, Britain, England, and all that, where so much of money and everything is there. But public satisfaction is on very higher side in the India, and उसका reason क्या था? पब्लिक सेटिस्फेक्शन बढ़ाने के कुछ तरीके होते हैं या उससे कुछ अपने इंडिकेटर है पब्लिक सेटिस्फेक्शन बढ़ाने के लिए। एंड उसमें एक जो सबसे बड़ा सिस्टम है वो है कि गवर्नमेंट शुड बी रिस्पॉन्सिव। यदि गवर्नमेंट को लगे कि हमारे सिटीजन्स जो हैं वो परेशानी में हैं, इमीडिएट गवर्नमेंट हैज टू टेक सम काइंड ऑफ डिसीजन टू इंटरवीन एंड ऑल दैट काइंड ऑफ थिंग। दैट गिव्स लॉट ऑफ सेटिस्फेक्शन। वन वन common example just I want to tell, in the medical college also, initially we faced lot of issue for filling up the gas cylinders and all that oxygen cylinders, and we became frustrated. We start caring about the government and all that. But one fine day government, they have just constituted a team, and they make a SOP kind of things कि कैसे हॉस्पिटल बारी बारी से नंबर से गैस प्लांट पे जाके ऑक्सीजन भराएगा। तो वो सारा सिस्टम जैसे स्टार्ट हो गया, वी फेल्ट सो मच इलेटेड एंड सेटिस्फाइड कि गवर्नमेंट ने इतना अच्छा इंटरवेंशन दिया। तो यहाँ पे गवर्नमेंट ने क्या किया, दे बिकम रिस्पॉन्सिव। तो जो पब्लिक सेटिस्फेक्शन है वो हमेशा इस चीज को देखता है कि हमारी जो सरकार है, हमारी जो गवर्नमेंट है, वो किस लेवल पे हमारी जरूरत के लिए रिस्पॉन्ड करती है। उसने रिस्पॉन्ड किया इवन फॉर द वैक्सीनेशन। It is again a disputed issue. Now the study says कि vaccination they are related with the heart attack and all that kind of incident. But if you see in the ethical term, if that time vaccination was not given, somebody is telling, somebody were talking कि नहीं vaccination was not fully tried and all that. But if vaccination was that time, it was not given, casualty maybe you cannot imagine how much casualty may be there. Okay, so sometimes we have to take such kind of decisions. They are the ethical kind of decision. It is something like that कि एक ट्रेन जा रही है जिसमें 500 आदमी बैठे हुए हैं और पटरी पे एक आदमी आ गया, एंड आप यदि ट्रेन रोकते हो तो पूरी ट्रेन डिरेल हो जाएगी, उसमें 500 आदमी भी मर सकते हैं। जबकि आप यदि पटरी पे चला देते हो तो एक आदमी मरेगा, बट एटलीस्ट 500 लोग बचेंगे। दिस इज ए काइंड ऑफ ethical situation where you have to, in medical में you have to take such kind of decision. In the ICU also you have to take, सपोज एक बहुत सीरियस पेशेंट है जिसको बचने की उम्मीद है, और दूसरा पेशेंट है जिसको बचने की उम्मीद नहीं है, उसको आपने वेंटिलेटर में रखा है। तो एथिकली आप क्या बोलोगे कि नहीं हम उसको वेंटिलेटर से नहीं हटा सकते, लेकिन एक दूसरा एथिक्स ये बोलता है कि द person who has chance for survival, we should give the facility to him rather than utilizing or the consuming our ventilators or our resources on a patient who cannot be revived, who cannot be survived, or who is at the end stage of life. So these are all the a lot of ethical issues which are into the medical field, and where the patients are serious, then of course these ethical issues are arriving more. Okay. तो दीज आर द सम प्लानिंग उस समय जो हम लोगों ने आईसीयू में आईसीयू की प्लानिंग किया, डेजिग्नेशन एंड आइसोलेशन आईसीयू। एंड इस आईसीयू में सबसे खास बात थी कि हमें हमें एक नेगेटिव प्रेशर आईसीयू क्रिएट करना था। नॉर्मली बिफोर कोविड नोबडी थिंक्स अबाउट दिस नेगेटिव प्रेशर एंड ऑल दैट। एंड नेगेटिव प्रेशर क्यों करना होता है? जब भी ड्रॉपलेट तरीके का जो इन्फेक्शन होता है, उसमें एम ये होता है जो हमारे इन्फेक्शन है वो बाहर के एटमॉस्फेयर में जाके ना मिले। तो दैट इज व्हाई वी हैव टू क्रिएट द नेगेटिव प्रेशर। नहीं तो क्या होगा, यदि पॉजिटिव प्रेशर होगा, एंड इट्स नॉर्मल फिजिक्स कि पॉजिटिव प्रेशर से हवा जो है वो हाई लो प्रेशर में जाती है, तो क्या होगा, इन्फेक्शन सब मिक्स होगा। इसलिए हॉस्पिटल में आप आज अभी भी देखोगे जो आपके टीबी वार्ड वगैरह है जहाँ पे चेस्ट इन्फेक्शन होता है या ड्रॉपलेट इन्फेक्शन के चांस होते हैं, वहां पे उस रूम को हम नेगेटिव प्रेशर बनाते हैं। तो उस समय ये सारी चीजें हुई। बट जिस हॉस्पिटल के पास नेगेटिव प्रेशर नहीं था, तो इसका मतलब ये नहीं कि वो हॉस्पिटल बंद हो गए। देयर आर लॉट ऑफ वेज एंड मीन्स, एग्जॉस्ट फैन लगाए गए, नेगेटिव प्रेशर क्रिएट किया गया, बहुत सारी चीजें की गई। तो दीज आर ऑल द रिक्वायरमेंट ऑफ द टाइम। मतलब व्हाट आई हैव टोल्ड इन द इनिशियल स्लाइड, at that time there was no sophisticated ventilator, but even after the polio pandemic we used that kind of ventilator. Okay, तो कहने का मतलब ये है कि even we don't have facilities, but if we can think innovatively, there may be some kind of solution which can not, I am not saying that there is no solution, but which can not, I am not saying that there is no solution, but as a hospital administrator, it is our responsibility also how we can manage the situation with the best possible solution. limited resources. That is the area. Talk about some quality assurance, ki how we can ensure the quality. As we know, ki quality is one thing for which everybody is perturbed. सभी को लगता है कि क्वालिटी होना चाहिए एंड क्वालिटी है क्या क्वालिटी इज नथिंग व्हाटएवर वी यू आर एक्सपेक्टिंग if you are getting that thing but you are you are not getting there and it varies from class to class, it varies from gender to gender also, it varies from economic class, all that administrator you have to work on this कि लोग क्या चाहते हैं and you have to just fulfill the expectations of the individual, then only they feel the quality. So in any case we have to monitor certain indicators which is they are the indicator of the quality in the service. Staff availability होनी चाहिए, bed availability है, turnaround time for making bed, reporting time of investigation, that is one important, medical administration, root dose and frequency, ICU in charge and all, coordination between staff and ICU. तो ये सारे परफॉर्मेंस इंडिकेटर हैं विच आर द इंडिकेटर फॉर द सर्विस क्वालिटी एंड बेस्ड ऑन दैट हम उसको मेजर करते हैं एंड उसको मेजर करने के लिए हम एक टाइम सेट कर सकते हैं और एक वो कर सकते हैं एंड लेटर ऑन जब हमारी क्वालिटी की मीटिंग हो then we can discuss on that particular indicator and we can see whatever the benchmarking has been done how much we are deviated from that benchmarking. So in any area, we have to see this quality about any services. Now we will talk about this future of critical care. What maybe grossly changed now. The artificial intelligence they have taken over lot of technology things. But if you see now we have Internet of Things, that is the equipment which are run by the internet connectivity. There are various wristband, various glucose monitor kind of system. All that kind of systems we have there in there, and that technology can be utilized for the better care of the patient. Now the whole ICU can be monitored by a single doctor by sitting at a remote location, and he can guide or he can tell the staff how what to do based on the complaint or based on the patient condition in the cameras or sometimes given information by the staff or the nurses, something like that. So all these the digital technology we can utilize in this ICU or in the healthcare sector, and purpose of that utilizing that is to just give the relief to the patient. Today or 2 3 4 days now we see this LLM, large language models, chat gpt, deep ci, all that kind of thing. Now chat gpt at least they have taken some good step, and now they have just denied to give any kind of information which is related with the medical in terms of the clinical situation or some kind of suggestion about the drugs. Now they have just discarded. If you type such kind of prompt right now, you will not get any kind of information. Just you type ki what drug to be given in the fever, जो पहले वो लिख के दिखाता था कि you can give the paracetamol 500 या 650. Today onward, you will not get to see whatever the prompt you just put it. Chat GPT is not going to tell something about your medical condition or not going to suggest any kind of prescription. So that kind of check is also required. Artificial intelligence is not a bad thing, but in medical, if you see the paper and all that, lot of people they have suffered because of this prescription from this AI. They are suffering from very serious kind of disease or some kind of thing. So we have to make a balance between the artificial intelligence and technology and the manual involvement. In any case, there is no replacement of the human touch or the human care, face to face care. But there, it is again, there is no doubt this technology can help a lot. Even in the remote location, now you see, if somebody is sitting in some Meghalaya in a very remote area, उसका एक एक्सरे का रिपोर्टिंग होना है, उधर एक्सरे रेडियोलॉजिस्ट नहीं है, who will report that? But now the technology make it possible. Now you take the X-ray, that radio film that can be sent digitally to the person, doctor sitting at the Bangalore. He just see the report and he just see the film and he can send the report to the that far-flung area of the Meghalaya. So these kind of technologies, telemedicine, now the every public facilities from the grassroots, from the Ayushman Center, that they are the most basic unit for this healthcare in the public. Now everybody is now it is mandated by the government that they should utilize this telemedicine. Why? Because it is not feasible. You know the resources of our country. There are limited number of doctors. We are the most populous country, more than so much 150 and something like that. So you can imagine ki how it is feasible to provide the doctors at every each and every place. And irony is there. Ki most of the doctors they want to be available in the one tier city or the two tier city because of the living standards and the comfort for their educations and all that kind of thing. So, to how to make the balance in between all these things, that is only the one thing that can help us. That is the technology. So we have to utilize the technology in a proper balance kind of manner. Okay. And this is the last slide. We want to save lives and return people to their normal life. This is the the saying of this Florence Nightingale.